Good evening, everybody. Thank you for joining us. I think we can go ahead and get started. We have a very nice turnout. My name is Ann Dodge, nurse practitioner and senior care navigator for the Family Heart Foundation. I would like to welcome you all to our Family Heart Foundation Pediatric Lipid Screening webinar titled, Why is there controversy about universal screening for high cholesterol in children? We are so pleased that Dr. Amy Peterson from University of Wisconsin is joining us for this presentation. Next slide. Just to let everybody know, the information in this webinar is for your information. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute other professional advice. Medical information changes frequently, so information in this webinar can be updated or changed in the future. Please follow up with your medical team or other professionals for specific questions regarding treatment of your patients. It says family there, but it's also for any of you that have questions about your patients. You can feel free to reach out to the Family Heart Foundation. Next slide. We would like you to introduce yourself and tell us where you're from. You can use the chat for that, and make sure when you do that, you change the settings to everyone so that we can all meet you. Thank you. Next slide. At the end, we welcome your questions. If you have questions, please enter them into the Q&A area down below to the right of the chat button. I will be tracking those questions and will direct them to Dr. Peterson at the end of the webinar. And we ask that you ask questions generic. They can be about one patient, but just as long as we don't use any identifying information. Next slide. I would like to thank our generous corporate sponsor, Regeneron, and Family Heart Partners for the 2024 LEAD Plus Pediatric Cholesterol Screening Initiative. Next slide. I now have the honor of introducing our speaker, Dr. Amy Peterson. Dr. Peterson is a pediatric cardiologist and director of the Pediatric Preventive Cardiology Clinic at the University of Wisconsin School of Medicine and Public Health. We are very pleased that she also serves as a scientific advisor to the Family Heart Foundation. Her research spans many areas of pediatric lipidology, including universal screening and implementation of universal pediatric screening guidelines. Welcome, Dr. Peterson.
Thank you so much for that kind introduction, Anne. I really appreciate it. And thank you for the opportunity to join everyone tonight. So I'm going to be discussing, why is there controversy still about universal screening for high cholesterol in children? So to really take a step back and to think about every set of pediatric screening guidelines that have ever been written, the main goal of all of those screening guidelines has been to identify and treat inherited genetic cholesterol conditions like familial hypercholesterolemia. There's been a huge shift in focus incorporating children with obesity, metabolic syndrome, things like that. And I definitely do not want to be dismissive of those children's concerns. But the real purpose has been to identify and treat FH. Many people here are going to know what FH is, familial hypercholesterolemia. But really what it is it's an inherited disorder of LDL cholesterol metabolism, where LDL levels in the blood are markedly elevated from the time of birth. We know it affects about 1 in 300 people through autosomal dominant inheritance. So it's actually an incredibly common condition. And therefore, because of that autosomal dominant inheritance pattern, we know that cascade screening, meaning checking first degree relatives to see if they share the condition, is essential to meaningfully detect FH. So the reason we care so much about FH and why we're thinking about high cholesterol in children is that we know that the cumulative exposure that a person has in LDL levels over the course of their lifetime will determine when they start having cardiovascular events. So one of the main analogies I use when I'm explaining this to a family is smoking. So if you start smoking when you're 10 years old and you start and you finally quit when you're 55, like that's great. Your health will be better after you quit smoking at 55. but nobody thinks for a minute that we didn't have damage being done during that time period, and some of that damage may eventually be irreversible. So if we think of LDL a little bit like smoking in our blood vessels, it kind of helps the rest of this make sense. So this is a mathematical model that that describes the cumulative LDL exposure and then over the age and years. So most of us in the population will fall under this this greenish line here. These are individuals without FH, and this is based on NHANES data, so the National Health and Nutrition Examination Survey data. What this is showing is that your LDL exposure over your lifetime increases, and most people will start to cross that threshold into cardiovascular disease around 55 years of age. If you do things like smoke, have high blood pressure, diabetes, other abnormalities in your lipid panel, that level could be brought down. And if you have a few protective factors like being a woman, it may raise that level a little bit. But most people, it's around 55. So these middle three lines here are the population with heterozygous FH. They've inherited one pathogenic variant, raising their LDL cholesterol. So if we do nothing and we just let them truck along on that LDL line, people with heterozygous FH are going to start to cross that threshold around 35 years of age. However, if we start to intervene and we start these individuals on a high dose statin right around 18 years of age, so the time they're leaving childhood, remember that, that's going to come back later. What can happen is we can bend that curve down. So by starting treatment, they become this lighter blue teal line, and they can cross that threshold into cardiovascular disease around 48 years of age. If we check even lower and we make the diagnosis and we start treatment around 9 to 11 years of age, also keep that number in mind, it's going to come back later, they become this purple line here. And they will actually get out to 53 years of age before they'll start crossing that threshold into cardiovascular disease. So it doesn't even quite get them back out to 55, but it's getting to be a fairly close approximation. I also think this curve is helpful to illustrate the fact that when a child is being treated with, a child with FH is being treated with a cholesterol lowering medication, I think a lot of those concerns about side effects from those medications stem from this idea that we're somehow ridding their body of cholesterol, like there's no more cholesterol in their body and we're just treating it and getting rid of it all. And that is actually not even close to the truth. Most of the pediatric guidelines recommend actually bringing children to the high end of the normal range or borderline elevated. So there is still plenty of cholesterol in their body for when they're going through puberty, when they're having growth spurts, they can make cells, they can make hormones. It really doesn't tend to be an issue. If you are one of those very rare individuals with homozygous FH where they inherit two copies, two pathogenic variants that knock out LDL function, these individuals can have LDL levels 800, 900, and they will start to cross that threshold into overt cardiovascular disease during childhood, and events in children as young as 3 have been reported. So that's a nice mathematical model. What does it look like in real time? So this is a seminal paper from the Dutch group, the Dutch Lipid Clinic Network. This came out in the New England Journal in 2019. And this was really one of our first pieces of concrete evidence that treating FH from childhood actually works. So what this group did is they had a group of children who are now 40, but what happened was they were part of some of the first trials of treating FH with statins in childhood. And so these children had been treated with pravastatin from about 13, 14 years of age. And what they did is they compared them to their parents who had started taking statins in adulthood. So most of those parents at this time had only been taking those statins for 10 to 15 years, primarily because the statins hadn't been approved. So they've only been available as a class of medication since the late 1980s. And so really what we're looking at is what's the difference between starting treatment 10 to 15 years earlier versus later. And I'll pull this up in clinic and show my families. I'll be like, which curve do you want your kid to be on? You can see the curve of the children treated with FH. One of the children, who's now an adult, had an event, but the parents at that same age, over a quarter of them had an event, and 7% were dead from their cardiovascular disease. And it's interesting to note too that the one person in the child group who had had a cardiovascular event was an individual who was treated during childhood, and he had stopped taking his statin when he turned 18. So we know that FH is underdiagnosed. In the US, less than 10% of people are properly diagnosed, meaning if you ask your patients if there's a family history of familial hypercholesterolemia, most of them aren't going to know they have it. A lot of them will think you're talking about a family history of high cholesterol, so they may answer yes for that reason, but most people don't know they have FH. And we also know that it's undertreated. Most patients still don't achieve LDL reduction goals even when they're properly diagnosed. And I hate numbers. I hate asking people to memorize numbers, but we should think about FH in a pediatric patient. The first threshold number to keep in mind is an LDL of 160 or higher. And about half of those patients will end up having FH, a genetic diagnosis. But that child with an LDL of persistently over 160, if they have a family history of early heart disease and you've eliminated secondary causes, this is a child that would qualify for a statin. If you have an LDL over 190 and your patient is under 20 years of age, in my mind, that's sort of FH until proven otherwise. And that child will have an 80% chance of having FH. Most of the other ones that don't have FH have some sort of polygenic high cholesterol, or they have a secondary cause of high cholesterol. So between 1998 and 2011, what we were all supposed to be doing was following the NCEP, the National Cholesterol Education Program, and the AAP guidelines. And I don't mind telling you, I did all of my training, my residency and fellowship during this time period, and I genuinely cannot remember checking a single person's cholesterol during my training. So it was not well adopted. And what we were supposed to be doing was screening children between 2 and 10 years of age with a family history of high cholesterol, early cardiovascular disease, or if you didn't know the family history. You would also screen if the child personally had overweight or obesity, hypertension, tobacco use, or type 1 or type 2 diabetes. This is sort of what we refer to as the selective screening strategy. You're identifying children with risk factors and you're going to screen them. And when this came out, the AAP predicted at that point that about 25% of children would meet criteria for screening. And they're quoted as saying that the guidelines would miss some children, but the children they missed would only have modest elevations in their cholesterol that were responsive to lifestyle changes. So what happened? So this study came out in 2010. This was the Cardiac Project, looking at 5th grade children in West Virginia. This was a huge effort with over 20,000 5th graders participating in this study. And what they did is they sent home 5th graders with an information packet about their family history. And then the parents filled that out. And then basically the kids came to school and they all had their cholesterol checked anyway. So regardless of what that screening questionnaire said, most of these children were white, slightly over half were female, and they were just about 11 years old on average. And so when we look at the cholesterol values on these 20,000 5th graders, first of all, what we see is that 70% of them met the guidelines for selective screening. So not that 25% before, 70% met selective screening criteria. And if you're looking ahead on the slide, you're going to quickly see it didn't matter. So the rates of elevated LDL, 130 is the threshold for elevation, was about the same in the two groups. It was actually a little bit higher in the group that didn't meet screening guidelines. And if you look at thresholds where you might consider medication with LDLs of 160, you can see it's actually higher again in the group that did not meet screening criteria. But the point is really no difference. So unfortunately, we know that those selective screening criteria don't really work if you want to identify children with high cholesterol. So 70% meant the selective screening criteria. Another thing to point out is that only a minority of the children actually had LDLs of 160. I think sometimes people get concerned that we're, trying to put statins in the water supply. But only 1.3% of these children had LDLs over 160. But even if you were flawless in your adherence to the selective screening criteria and you screened every child who met those criteria, you still would have missed almost 40% of children with significant cholesterol elevation. And so after this study and a few others showing similar findings, the AAP said that yes, if you follow our guidelines, you're going to miss probably half of children and adolescents with abnormal cholesterol. So why doesn't it work? A lot of you who are in practice can probably start to figure this out even without me saying it, but it's a long list of risk factors. It's clunky. to keep in mind, and it has poor predictive value. It just doesn't work. Our family histories that we take are often incomplete, they're often inaccurate, they're often unavailable, even in a cholesterol clinic. Sometimes it's that one of the parents is not involved. Sometimes we just don't talk about that kind of stuff with that side of the family. And very often I run into situations where relatives need to be in a position where they can access preventive care. So one example, if you have a family that has recently immigrated and you have relatives in the old country where perhaps preventive care isn't standard, they don't know if they have high cholesterol, they don't know if they have diabetes. So we just don't know this stuff. In the United States, we have a lot of adults, some of whom have FH, many of whom do not have FH, who are taking statin medications, which is great. That's what we want. But what happens is it lowers the significance of whether or not those cardiovascular events were premature. So for example, if grandpa has FH and he started taking a statin at 45, instead of his heart attack happening at 52, it might have happened at 58. So then all of a sudden, his heart attack is no longer premature. And so you wouldn't necessarily get flagged based on those age criteria. So a lot of pediatric preventive cardiologists are moving towards this idea that we should really not pay so much attention to the age at onset of the events. So then we moved on to the 2011 guidelines, and this is where the controversy started. So many things in this document, and it's 65 pages of glory. But the thing that really got everyone's attention were the cholesterol screening recommendations. So remember, this is based on data and ideas from 2011. I don't think many of us would rewrite these guidelines the exact same way today. But what we were supposed to do is screen based on age. So no screening for children under 2. The idea there was that only extreme cholesterol situations like homozygous FH would need to be found in that age group, and that is a rare condition. And at the time of these guidelines, there really wasn't effective treatment available. Between 2 and 8 years of age, we would use this selective screening strategy with a fasting lipid panel. Fasting, the idea being that the chance of the child having high cholesterol was higher, so you should skip the non-fasting screen and just go right to a fasting panel. Really, no one does that anymore. Pretty much all of us will just screen on it with a non-fasting panel now. It's just too inconvenient to miss the opportunity by making children come back and fast. Between 9 and 11, all children should be getting this non-fasting lipid screen. Between 12 and 17, you're supposed to revert back to the selective screening strategy. This is because there's some changes in cholesterol levels that occur during puberty. LDL levels will often drop. And so sometimes you could have a child who truly probably does have high LDL cholesterol, but will look normal during those age ranges. Nowadays, pretty much everyone would recommend catch-up screening. So if you have a child between 12 and 17 in your office and they've never had their cholesterol checked, just check them. And then between 18 and 21, we should all be repeating that non-fasting lipid screen. And this plan has been endorsed by many organizations, including the Family Heart Foundation, but other groups that you may recognize here as well. And so where some of this controversy comes from is the U.S. Preventative Services Task Force, which is a national, many of you may know, but a national organization that reviews evidence for different screenings for children and adults. And they reviewed universal cholesterol screening in 2016 and again in 2023. I want to take a point and say this was all about universal screening. There is really no controversy about children with a family history of cardiovascular disease or children with diabetes, obesity, hypertension, whether or not they should be screened. This was strictly the universal screening notion. And both times it got a level of evidence I, basically saying that there was insufficient evidence available to recommend for or against. And the idea is that individual providers should make a decision about whether or not they want to do it. And they offered, in terms of primary arguments against lipid screening, was that there was limited data on the effectiveness of treatment interventions, including lifestyle and lipid-lowering agents. We have quite good short and intermediate term data. The longest study is that 20-year study I just showed you, but we don't have any data on what being on a statin for 40 years does to your body, because there's no child or there's no 50-year-old alive today that has been on a statin for 40 years. There is limited epidemiologic data that quantifies that cardiovascular risk that's attributable to childhood dyslipidemia. However, we do have some data from the I3C cohort study, the International Childhood Cardiovascular Cohort, that we'll review. And thirdly, there's no direct evidence that screening for dyslipidemia in childhood will improve cardiovascular mortality in adulthood, i.e., if you screen a child, will that actually directly translate to improved cardiovascular mortality, in adulthood? And while this is listed as an argument against lipid screening, at the same time, the U.S. Preventative Services Task Force acknowledges that this type of a study is probably not possible. It would be cost prohibitive, time prohibitive to enroll enough children, screen some of them, not screen some of them, and then follow them into adulthood to see what their cardiovascular disease rates are like. I would argue, along with many other medical experts, that a study like this would also be highly unethical. And just to give it some context, there are actually other eye recommendations from the U.S. Preventative Services Task Force that many of us go along with and do anyway, because we believe that they're appropriate. Some of them are listed here. Preventing drug use, use your seatbelt and avoid alcohol while driving. And then some other ones listed here as well. So we do have some data that suggests that it turns out, if you have risk factors from childhood, your likelihood of having an ASCVD event is higher. So looking at, this is data from that I3C consortium. And what we see is that if you have an elevated total cholesterol or an elevated triglyceride level, your hazard ratio, your chance of having a premature cardiovascular event is higher. And if you have all of these risk factors, smoking, BMI, blood pressure, cholesterol, your risk actually goes up quite substantially. And looking at this, we know, just drilling down into the cholesterol numbers a little bit, elevated LDL and non-HDL are both linked to early cardiovascular events. So you can see for both fatal and the combined fatal, non-fatal cardiovascular events, having elevated cholesterol matters. It raises your risk for premature events. So if you've been paying attention to your inboxes or you get emails about lipid screening like I do, this is one that kind of blew up my email feed a few weeks ago. So this study just came out. This is also on the I3C consortium data. And basically all the headlines have been saying, should we even check kids' cholesterol? Checking cholesterol doesn't mean anything. A lot of headlines from that. What this study did is it looked at the risk factors that had been checked in the I3C consortium data. And what they did is they developed these two models. They used this non-laboratory model and the lipid model. So what they did is they basically used just the risk factors of overweight, obesity, hypertension, and tobacco use. So if you had these in childhood, that was one model. And then what they did is they took all of those risk factors and then they added in the triglyceride numbers, and they called that the lipid model. So the lipid model included all of those risk factors. And basically what they showed is that for the average person, if you had overweight, hypertension, and tobacco use, knowing your cholesterol panel did not increase their ability to predict whether or not you were going to have an early cardiovascular event. So for the average person, if you already have all those risk factors, we know your risk of an early cardiovascular event is going to be increased, and adding on the cholesterol panel didn't really help. That is what this study said. It did not say don't screen for high cholesterol. It did not say high cholesterol doesn't matter. And the authors actually even point out in the study that they're saying they know that this data does not say anything about familial hypercholesterolemia, which affects 1 in 250 to 300 people, which FH is an important reason to measure lipid levels in childhood as a clearly defined risk factor for ASCVD. What happens is when you're looking at 10, 15,000 individuals, only a relatively small number of them are going to have FH. And those individuals for which dramatic elevations in their cholesterol are going to make a huge difference for their risk, you just don't see it in this kind of modeling. The other thing that the authors point out with this paper as well is there was no gradation in this study, there was no gradation in terms of the severity of high cholesterol. So this just looked at, was your cholesterol abnormal or normal? Just binary. It didn't take into effect significant elevation. So it's quite possible, since most people, if they have high cholesterol, only have a mildly elevated cholesterol, it might just simply be saying, okay, if you already are overweight, have hypertension, and you smoke, and we know your triglycerides are 170 instead of 140, maybe that doesn't make that much of a difference. Which, if you think about it, yeah, that starts to make some sense. But really what we're looking at here is, this is not saying that we shouldn't be screening kids for FH and for high cholesterol. All right, so our take-home points. So the big one here, if you remember nothing else from this, is really when we're screening kids for high cholesterol, what we're doing is we're looking for genetic forms of high cholesterol, like FH, that are raising a child's risk for early ASCVD. If we happen to find mild abnormalities in children who have other risk factors, and that motivates a family to make lifestyle changes, and the numbers get better, that's amazing. That's great. But that's not really what we're after when we say screen every child's cholesterol. The other point is, the kids who have high cholesterol that's due to obesity are generally not the kids who need medications for cholesterol. Now, there's the whole topic of medications for obesity. And I would say usually. However, we do know that pediatric obesity is so common now that kids with FH may also have obesity. So in my clinic, for example, approximately half of my patients, my pediatric patients with FH, also have obesity. And we know that's not because FH makes you have obesity or those two are related. It's selection bias. Children with obesity are more likely to have their cholesterol checked. They're more likely to be referred. They're more likely to keep the appointment and have their FH diagnosed. And the last point basically is, if you're not looking for high cholesterol, I promise you, you're going to miss it. It's a numbers game. It's 1 in 250 to 300 people. If you're not looking, you're not going to find it, because kids with FH have no symptoms. And if we were only focusing on high-risk children, we're going to miss a lot of children who actually still need treatment. And I would also drive home the point is that if you are finding a child with FH, you didn't actually just find a child, you actually found a whole family, because most of those families have no idea that they have FH. And so you may actually save a life by screening. It may not be your pediatric patient's life that you save. It may be that parent sitting in the room who has no idea that this is what's going on. Leaving with a parting thought, if we can find a way to effectively address cardiovascular risk in childhood, this may be actually our single biggest opportunity to impact human health. So thank you very much, and I'm happy to take any questions.